In this lesson, we will study Chapter 18, Symptoms, Signs, and Abnormal Clinical and Laboratory Findings, Not Elsewhere Classified, covering code range R00 through R99. This lesson is for educational purposes only. Please refer to official ICD-10-CM guidelines. Learning objectives. After completing this lesson, you will be able to correctly apply Chapter 18 coding rules, determine when symptom codes may or may not be assigned, understand combination code logic, and accurately code special scenarios such as repeated falls, coma scales, non-infectious SIRS, death not otherwise specified, and the NIH stroke scale. These concepts are frequently tested on CPC and CCS examinations. Overview of Chapter 18. Chapter 18 includes symptoms, signs, abnormal clinical findings, abnormal laboratory findings, and ill-defined conditions that cannot be classified elsewhere. These codes are used only when no definitive diagnosis has been established by the provider. Once a confirmed diagnosis exists, Chapter 18 codes are generally not assigned unless specifically permitted. When symptom codes are acceptable. Codes describing symptoms and signs are acceptable when the provider has not confirmed a definitive diagnosis. This commonly occurs during diagnostic workups, emergency department visits, or observation encounters. This scenario is frequently tested in CPC examinations. Symptoms with a definitive diagnosis. In some cases, symptom codes may be reported in addition to a definitive diagnosis. This is allowed only when the symptom is not routinely associated with the diagnosed condition and represents a distinct clinical issue. In such cases, the definitive diagnosis must always be sequenced first. Routinely associated symptoms. Symptoms that are routinely associated with a disease process should not be coded separately. ICD-10-CM assumes these symptoms are integral to the diagnosis unless the classification provides explicit instruction otherwise. This rule is designed to prevent overcoding. Combination codes including symptoms. ICD-10-CM includes many combination codes that identify both a definitive diagnosis and its common symptoms. When a combination code is assigned, additional symptom codes must not be reported, as the symptom is already included. Repeated falls. R99.6, code R29.6, repeated falls, is assigned when a patient has recently experienced falls and the cause is actively being evaluated. This code reflects an active clinical concern, not a historical condition. History of falling. Z91.81, code Z91.81, history of falling, is used when the patient has fallen in the past and is considered at risk for future falls. This code represents past history and risk, not an active evaluation. R29.6 vs Z91.81. To summarize, R29.6 represents current or recent falls under investigation, while Z91.81 represents a history of falls and future risk. Both codes may be assigned together when documentation supports both conditions. Coma. Unspecified. R40.20, assign R40.20, unspecified coma, when the cause of coma is unknown or when coma results from traumatic brain injury and no coma scale is documented. Coma codes not to be used. Do not assign coma or coma scale codes for medically induced comas or for patients who are sedated. These conditions do not meet the clinical definition of coma. GCS code range. Glasgow Coma Scale codes range from R40.21 through R40.24. These codes may be used with traumatic brain injury diagnoses, but they may not be used with non-traumatic coma code R40.2a. GCS coding rules. Glasgow Coma Scale codes must always be sequenced after the diagnosis codes. One code from each subcategory is required, and the seventh character must match across all three codes to indicate when the scale was recorded. Timing of GCS scores. At minimum, report the initial Glasgow Coma Scale score documented at presentation. If multiple scores are recorded within the first 24 hours, assign only the score at the time of admission. Total GCS score only. When only the total Glasgow Coma Scale score is documented, assign R40.24, which represents the total score without individual component values. Non-infectious SIRS overview. Systemic inflammatory response syndrome, or SIRS, may develop due to non-infectious causes such as trauma, malignancy, or pancreatitis. In these cases, no infection is present. Coding non-infectious SIRS. When SIRS is due to a non-infectious process, code the underlying condition first. Then assign either R65.10 for SIRS without acute organ dysfunction or R65.11 for SIRS with acute organ dysfunction. Organ dysfunction with SIRS. If acute organ dysfunction is documented, assign codes for the specific organ dysfunctions in addition to R65.11. If it is unclear whether the organ dysfunction is related to SIRS, the provider must be queried. Death NOS, R99, code R99, ill-defined and unknown cause of mortality, is used only when a patient is brought to a healthcare facility already deceased and is pronounced dead on arrival. This code does not represent a discharge disposition. NIH Stroke Scale, NIHSS. The NIH Stroke Scale codes, R29.7, are used to document neurological status and stroke severity in patients with acute stroke. NIHSS coding rules. NIH Stroke Scale codes are used in conjunction with acute stroke codes from categories I60 through I63. They are sequenced after the stroke diagnosis, and at minimum, the initial score should be reported. Common CPC exam errors. Common exam errors include incorrect symptom coding with confirmed diagnoses, misuse of fall codes, assigning coma codes to sedated patients, incorrect sequencing of GCS or NIHSS, and misuse of R99 as a discharge code. Exam recall summary. Remember, R codes are used when no definitive diagnosis exists. Routine symptoms are not coded separately. Combination codes replace symptom coding. R29.6 and Z91.81 are not interchangeable. GCS and NIHSS are secondary codes. R99 is used only for patients dead on arrival. Lesson 20 Summary. In this lesson, we reviewed the correct use of symptom and sign codes, combination code rules, repeated falls coding, coma and Glasgow Coma Scale guidelines, non-infectious SIRS, death NOS, and NIH Stroke Scale coding.